thank you very much for tuning in. I'm Rustam Al-Shahi Salman from the University of Edinburgh, and this is Professor David Werring from the UCL Institute of Neurology in London. So David, many congratulations on your publication of the CHROMUS-2 AF study in the Lancet Neurology today. You're going to be presenting it on behalf of the CHROMUS-2 AF collaborators in the presidential session this afternoon. Could you first explain to us why you went about this study?
So we are increasingly getting this clinical dilemma where we've got a patient with atrial fibrillation, they've had an ischemic stroke or a transient ischemic attack. We know that our goal of preventive treatment is to prevent another ischemic stroke. We've got extremely effective drugs for this. We have oral anticoagulants, vitamin K antagonists, and now the direct oral anticoagulants. However, we know that this very effective treatment, which reduces ischemic stroke by about 70%, comes at a small cost of intracranial hemorrhage. And this is an often devastating consequence of anticoagulation. It's probably the most feared complication by doctors and patients alike. And people have used various risk scores to try and predict this risk and therefore tailor people's treatment toward that risk. But they're not terribly effective at predicting intracranial hemorrhage. So if you look at most of the scores, such as the HAS-BLED and others, they have a C statistic of around 0.5, so they're not performing much better than chance. So we face this increasingly common dilemma where we have a patient like this who requires anticoagulation. We do a brain scan that includes blood-sensitive sequences, and this shows little black dots on the blood-sensitive sequences, which are cerebral microbleeds. And we know that in most cases, these are due to extravasation of blood cells from small vessels. So in other words, tiny areas of bleeding. Although there can be ischemic mechanisms for this, but this makes them a very plausible mechanism of bleeding-prone small vessel diseases, which seem to underlie most cases of intracerebral hemorrhage in older people. So the reason we did this study is that we're seeing these microbleeds in about 20% of people with atrial fibrillation, and the hypothesis and the concern is that they may reflect an increased risk of macroscopic symptomatic intracranial hemorrhage. That's why we did the study, to try and investigate that question.
Okay, so CHROMUS-2 AF is very much a response to the modern dilemmas that are being thrown up by imaging. And as I understand it, there was not much information about the association between microbleeds on MRI and the risk of intracranial hemorrhage with oral anticoagulation before you embarked on this study.
That's right. When we initially embarked on getting the funding and doing the study, that was about 2008. There was very little information at all, actually, in fact, none. So this was a dilemma. People just did not know what to do about these microbleeds.
Okay. So CHROMUS-2 AF is probably the largest definitive study that's been published about this after this long period of time when people have been gathering data. So we'll come back later to what other information's out there. But could you just describe briefly the design of the CHROMUS-2 AF study?
So we did an observational study, and it was a prospective observational study at multiple centres throughout the United Kingdom, one centre in the Netherlands. It was conducted at about 80 hospitals. And it was an inception cohort study, so we wanted people who were treated with anticoagulants for the first time, because at the time we were designing the study, there was some evidence that these patients might be at higher risk of intracranial hemorrhage than those who'd already sort of had a trial of anticoagulation and hadn't suffered any hemorrhage. So these were patients exposed to anticoagulants for the first time. And we tried to design it as carefully as we could, in the sense that we had standardized brain imaging at baseline, because we know that microbleed detection is heavily dependent on sequence parameters. So we had a rather carefully specified protocol that was adopted by all the centres at baseline. And we used multiple overlapping methods of follow-up to try and ensure that we got good follow-up, because we know that intracranial hemorrhage is rather a rare event, thankfully. And we knew that we really had to try and capture all of the events. So we used patient questionnaires, GP questionnaires, centralised follow-up, hospital records, NHS records, and so on.
Great. And this study was based in the United Kingdom. And how many hospitals were involved?
So it was 80, 79 in the UK and 1 in the Netherlands.
And how many patients did you recruit in the end?
We recruited just over 1,400 altogether.
So a good sample size. And what was the average duration of follow-up?
The average duration of follow-up, well, the specified years of follow-up was 2 years, and we got 3,366 patient years of follow-up. And I think the mean was about 850 days.
Okay, good. So you will have encountered some intracranial hemorrhages during follow-up, which is your primary outcome of interest. Roughly how many of those were there?
There were 14. And of those, most of them were intracerebral hemorrhages, but there was one subarachnoid, one subdural.
Okay, so what did you find about the association between microbleeds on the baseline MRI and the primary outcome of intracranial hemorrhage during follow-up?
So we found that those with microbleeds had a higher rate of intracranial hemorrhage during follow-up. So it was 10 per 1,000 patient years in those with microbleeds, and it was substantially lower in those without microbleeds. So it was 3 per 1,000 patient years in those without microbleeds.
Okay, and that was a statistically significant difference.
It was, and when we did an adjusted survival analysis, we found an adjusted hazard ratio of 3.67 for the presence of microbleeds.
Okay.
And that was in our pre-specified statistical analysis plan.
So microbleeds were independently associated with your primary outcome. Okay. And the anticoagulants used in the study, what were they?
So they were vitamin K antagonists in around 60% and direct oral anticoagulants in about 40%. And it was a mixture of DOACs. I think rivaroxaban was the commonest, but also some were on apixaban.
And presumably you were challenged to look at differences between those types of oral anticoagulants for their association with the primary outcome.
We were, although because the numbers of events were so small, but we were able to show that the DOACs seemed to be less often used in those with intracranial hemorrhage. In other words, warfarin was more likely to be associated with intracranial hemorrhage.
Okay, so that's your finding about the independent association. Did you look at whether microbleeds might add to existing prediction models like the Hasbled that you mentioned earlier?
So yes, we did look at that, and we looked at the C statistic of the Hasbled score on its own, which didn't perform terribly well. It was about 0.4, and then when we added microbleeds to the Hasbled score, it increased the predictive ability. C statistic was 0.66, and then when we looked at all the predictors that we found in our baseline data that predicted intracranial hemorrhage, it was about 0.75, something like that, and those were statistically superior to the Hasbled on its own.
Good. And a last message for our viewers about where you're going next with this study, in particular in the light of the other studies that have been done addressing a similar question.
Yes, so the challenge we've got is that we still didn't have a huge number of outcome events, and we'd really like to investigate whether an increasing microbleed burden could actually tip the balance away from net benefit from anticoagulation, because what we haven't discussed is that microbleeds actually predicted ischemic stroke as well, although they weren't a statistically significant predictor. So what we're planning is an international collaborative effort, so far with around 18,000 individual patient data sets, to look at this question in worldwide cohorts, and hopefully we'll be able to validate our findings and maybe look at microbleed burden to see if that affects the balance of risk, and we can ultimately predict patients who might be harmed by anticoagulants.
Excellent. Well, we very much look forward to the findings of that collaborative work, but in the meantime, our viewers can read the Chromis 2AF paper online in the Lancet Neurology from around about 3 o'clock this afternoon. So, Professor David Waring from the UCL Institute of Neurology, thank you very much.
Thank you, Rusty.